malignancy with limited systemic therapy option. Nowadays, gemcitabine in combination with the cisplatin is the standard of care for patients with advanced cholangiocarcinoma, but the results remain poor. Recent study showed that genomic profiling of cholangiocarcinoma has identified unique molecular signatures such as genetic aberration in isocitrate dehydrogenase, IDH, and fibroblast growth factor receptor fusion, FGR fusion, that are attractive therapeutic targets. However, inhibitors of FGFR and IDH have shown limited success with only a modest improvement in outcomes. So the first question is, do you envisage next promising molecular targets identified by NGS study to treat cholangiocarcinoma? What is your opinion in that?
Well, great seeing you, Dr. Fabrice, and so nice to connect. And congratulations for Hepatoma Research for the great efforts in their journal. And of course, at the same time, we're very grateful to have us featured in their journal with this interview. And you're absolutely right, Dr. Fabrice. If anything, cholangiocarcinoma is becoming a more recognized disease. Understandably, diagnosis is definitely improving quite markedly. Now it's being pinpointed down right from the start as being a biliary tumor rather than the classic old history unknown primary. In addition to that, sadly, there's a clearly increased incidence. We don't have yet a read about why, but definitely something to keep an eye on to see how it evolves in that regard. Now, of course, the big plus is exactly what you said, is that the advent of therapy has been really going rather robustly and fast. Historically, we borrowed all the therapies for the intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder from their neighbor, pancreatic cancer. And we always based therapy on gemcitabine-based treatment because we did not do better. We give a lot of credit for the effort that was done in the UK by our dear colleague, Dr. Vali, in regard to the gemcitabine plus cisplatin. Know that it might be simplistic, but to be fair, this is where the complexity is in the simplicity, because this was a very monumental study published in the New England Journal of Medicine because it established a very important standard of care therapy for biliary tumors, and at the same time could be a reference point for any futuristic work that could have been done. From that point on, three routes kind of like traveled in three directions. One of them, exactly as you said, is like, to enhance the therapy. Sadly, adding on more chemotherapy did not work. And we saw the SWOG 1815 study that looked into gemcitabine, cisplatin, and nab-paclitaxel and did not fare out. There was no improvement in survival. It was a negative study. There was, of course, added toxicity to the three drugs, which makes sense. It's understandable and expected and anticipated per se. From that point on, the efforts really focus in two directions. One of them is on the use of the immunotherapy or checkpoint inhibitors. And the other one is in regard to the biologic therapies or targeted therapies. I will hold off on the checkpoint inhibitors discussion because I'm sure we're going to discuss it in a second. But let's talk a little bit more exactly what you asked in regard to the targeted therapy. And you're absolutely right. Actually, some genetic alterations have been already addressed for two reasons. Number one, we know they exist in regard to biliary tumors. And number two is because we know that we have a drug for them. One of them is the IDH1 mutation, which, if anything, we know that hydroxyglutariate will be kind of adjusted, and the ivosidenib therapy will be able to inhibit that kind of uncontrolled growth and improve outcome. The study that randomized patients to ivosidenib versus placebo was successful. It was already published. We proudly did lead it here from Memorial Sloan Kettering in New York. And the study showed an improvement in progression-free survival against placebo. Now you might pause and ask me, wait a minute, like why progression-free survival? We are always used to overall survival. And you're absolutely right. However, there was a very important voice which we are delighted and we respect very much, which is patient advocacy. If a patient said, well, but I have the mutation for IDH1, why should not I get the drug? And so there was a force to really push us to give the drug for everybody because sadly, it's not like there are too many options. So for that reason, we decided to do the study with a primary endpoint being progression-free survival, permitting as such the patient to cross over from progression-free survival from the placebo if they don't benefit or there is progression to the ivosidenib arm, and as such overall survival will not be possible in that design. However, there is a certain statistical tools that maybe will keep the rank preserving, i.e. will pretend as if patients did not cross over and continue on the placebo, and they will be able to calculate it. And actually, there was clearly an improvement in survival as well. So the drug is approved by the FDA in the United States, as well by other agencies throughout the world. We're delighted we have it. The drug is very well tolerated. The drug is definitely showing a great benefit, and we have patients already that have been on the drug for a long period of time. Now, here we'll just pause on 1 second because we're going to come to that discussion a little bit later on. This is available only in second-line therapy after trying the other interventions, as we spoke already, the chemotherapy, but we're going to talk about immunotherapy in a second as well. Now, the other genetic alteration which you spoke about is the FGFR fusions. This is like a fusion of two alterations calling the FGFR2 fusion, but there could be other mutations, other translocations, other enhancement of the FGFR. And this was actually quite exciting enough that there are many drugs that really kind of were really looked into that. We proudly contributed to a couple of them, among which the one that we proudly led from Memorial Sloan Kettering is the pemigatinib, which is again anti-FGFR2 fusion therapy with a clear improvement in regard to outcome. Within a phase 2 component, this was a response-driven study, but an anticipation of survival showed it, especially among responders. People definitely do benefit from therapy and they survive a longer time. The classic challenges in regard to the pemigatinib and other anti-FGFR2 therapies is the adverse events or side effects, among which, of course, is the elevated phosphorus. A close monitoring will be more than needed. We learned through the clinical trials, don't overtrade the hyperphosphatemia because you make it hypophosphatemia. That's not what the aim is. Look by symptomatology as well. A 1A exam at least once as a baseline is needed, and we published on that in JAMA Ophthalmology. And of course, hand-foot syndrome in regard to the hands and feet to keep an eye, and of course, involved dermatology is needed. Now, again, one more time, this was only available in, or still available only in second line. At the moment, there are two of them available, approved by the FDA, pemigatinib, and the other one is futibatinib, which is more targeting for other FGFR, but as I understand, still not available. We don't have the drug yet available for us. And the third one was infigratinib, which was withdrawn from further evaluation and retracted from the market because the sponsor decided that they will not move it any further. And this, of course, brings us to the next question in regard to, and you probably will ask me, what about those therapies in first-line therapy?
Okay. Thank you, Ghassan, for this very thorough analysis of the problem with the therapy option in cholangiocarcinoma. It is important because you mentioned the New England Journal paper of 2008, if I remember well, 2012, showing for the first time that cholangiocarcinoma was indeed as a therapeutic option. Before that, nobody can do anything on this apart from surgical resection. So I think that in these 10 years, in the last 10 years, it has been a really good advance in understanding the mechanism of the disease. But one important point is that the effectiveness of therapy is strongly limited by the emergence of chemoresistance. And I know that you are an expert of combination therapy. So what is the role of combination therapy as a strategy to circumvent chemoresistance in cholangiocarcinoma? What is your opinion on that?
So no doubt that the dimension, Luca, have been going in different directions, because one of them, as we just spoke, is to try to see if we can move all those targeted therapies to the first-line treatment. And there has been an attempt actually to do that. There are clinical trials, and I would say humbly and proudly, we were leading one of them all over the world, looking again one more time at the standard care therapy being like gemcitabine cisplatin versus the anti-FGFR2 therapy. These are very difficult to accrue because, as you started in the beginning, the chance for a genetic alteration in those tumors is rather uncommon. It's not really that common. And in other words, it will take long time to be able to approve those drugs through a phase 3 clinical trial. And that's why actually infigratinib, as I just mentioned, was retracted from the market. On the other hand, I hope and I wish that we can see the agencies worldwide, including the FDA, look into those uncommon alteration in uncommon disease in an uncommon entity being approved only by phase 2 trial and not depend on phase 3 trials. With this said, the overcoming resistance, as we thought first, and I just mentioned that already, adding chemotherapy did not work. We already spoke about the triplet of gemcitabine cisplatin and nab-paclitaxel was a negative study. But interestingly, another helper came, which is the immunotherapy. And durvalumab, add on to gemcitabine cisplatin, was studied extensively in a phase 3 clinical trial that showed improved survival, and ultimately led to the approval of durvalumab in first-line treatment along with gemcitabine cisplatin. Now, this is interesting here because how do we do it? As you know, our colleagues in the UK, even when they did the ABC0 study that you already referred to, they limited chemotherapy only for 6 months. Why is that? The UK respectfully have a certain perspective that does not necessarily apply or even were used anywhere else in the world, where we say we treat only for limited time. We kind of, evaluate benefit and quality of life. We kind of like calculate what's the benefit for patients. There is certain pricing for price of life that the UK, the United system has put in. This is not to say like they don't value life, but this is really what's important on a big scale of economic governmental decision-making. In the US, we don't do that. In Europe, in other words, also we don't do that. But nonetheless, the durvalumab, when add on to gemcis, because they wanted to go by the standard, whatever what the standard is, and as you said, this was the New England paper, they did the chemotherapy for 6 months, and then they maintained durvalumab as a maintenance therapy. Now, the question is, what do we do day to day now because of that resistance you spoke about? We're getting actually 3 scenarios. Scenario number 1, that sadly patient don't respond or benefit from therapy, then respectfully, it means it's not working. We have to move on to something else. And we'll talk about second-line therapy in a second. The second scenario is exactly as they designed it. You have great response. And I really mean by that a good partial response that really robust and solid. I can see why I would stop the chemotherapy and will continue with the durvalumab. But also you have the patient with stable disease that are just maintaining therapy. As you and I know, the add-on of the checkpoint inhibitors is really dependent on the presence of the chemotherapy. because these are not very immunogenic tumors, and they really need to be kind of like enhanced and driven by something that will enhance their potential to benefit from, and that's why the chemotherapy. In practice, I realized that even because I did that attempt, I had actually even a CR, impressive. We had a complete response on 2 patients on the triplet. And we stopped the chemotherapy and we kept the durvalumab, but guess what? The tumor kind of like sluggishly, but definitely was going back. So as such, we're coming to a variant of that. We don't have clinical data on, but if we think that the cisplatin could be a little bit the robust kind of, challenging drug to keep on because of the prolonged and cumulative side effects, among which neurotoxicity and renal toxicity, you can consider gemcitabine plus durvalumab after you have the response per se. While the patients with stability disease, I'll continue the 2 drugs until I get at least a opportunity to stop the cisplatin if I can. But to keep on durvalumab alone, I'm yet to see that, yes, we're going to have those patients with continuing only durvalumab so far. I'm sure it will happen, but so far my experience with the 2 CRs has been to keep the gemcitabine on.
Thank you, Ghassan. Very, very clear, very focused on my question. You mentioned starting our discussion of the similarities between cholangiocarcinoma with the neighbor, the pancreatic cancer. And we know that an hallmark of both the disease from a morphologic point of view is the abundant microenvironment that grow in parallel with the tumor component. But the tumor microenvironment is a multi-ethnic society where many cell types are resident. Which cell type is the most suitable for therapeutic manipulation? I mean, cancer-associated fibroblast, tumor-associated macrophages. Do you envisage any future direction in this respect? In particular, are cancer stem cells amenable of intervention? Because this should be a great point worth of consideration in reducing the likelihood of recurrence of the tumor. What is your opinion?
So no doubt that the tumor immune microenvironment is a dynamic status that's not necessarily sitting there, because of course it's affected by whatever intervention we do in between as well. Admittedly, so far we did not see yet data in regard to what does it mean specifically, or how would we tackle it specifically in biliary tumors. And I'm sure there'll be a lot of data coming in that regard, but you are yet to see it per se. But I can probably borrow a little bit here from the other neighbor, which is liver cancer. Exactly. And if anything, we have seen that in general, a high Ki67, high CD4, high CD8 tumor will probably be most kind of amenable to therapy and intervention. However, it's very important to note that what we have seen in other tumors, like in melanoma, lung, etc., gastric, in regard to the CPS score and what is the at least best read on regard to the immunoprofile of the tumor, has not been really of any implication regarding biliary tumors. And in other words, even though these were tested in the Topaz 1 study of the gemcitabine, cisplatin, and durvalumab, also they were tested in, as you know, the Himalaya study in liver cancer that I again proudly led all over the world for durvalumab, tremelimumab, which was also positive. But interestingly, it did not matter. In other words, we wouldn't even measure them. But does it mean that we should not but understand the immune microenvironment? Of course we are. And this invites me to tell you about the great work we're doing. And this is like, of course, invitation for you, Luca, and of course for other colleagues who are listening to us. We are collecting actually tissue from all over the world, not just tissue, but also demographics. And we're trying to look at the immune microenvironment for liver cancer, and we hope to do the same for biliary tumors as well, based on geography, race and ethnicity. And we'll see if
and
this
gender
will
maybe.
give us exactly
And
with
gender
as
maybe.
well. Absolutely, absolutely. Or sex. This is very important biological component. So that's really what really we're doing at the moment. And hopefully we'll be able to, as you and I would aspire, we're very delighted where we are in regard to liver cancer, to biliary cancers. And ultimately, our aim is not to say, oh, we'll try that, but ultimately, our aim is to have really a custom-made therapy for every patient.
Oh, that sounds absolutely interesting, Ghassan. Very, very interesting proposal. I think we will have plenty of new data about even because to go to see the essence of the disease in the across the different ethnicities, I think is really a good step ahead in this respect. And you mentioned several times immunotherapy as a second line, third line, and you also mentioned that cholangiocarcinoma maybe is an immunological cold tumor we compare with others. Why do the results from immunotherapy have been so far so disappointing compared with other the master in this field that are lung cancer, colorectal cancer, melanoma? What is what is the future direction of immunotherapy in cholangiocarcinoma? What is your feeling in this sense?
Well, thanks so much again. No doubt that there are relatively cold tumors, but now, and thanks to our colleagues, especially in melanoma, we knew how to warm it up and that the immune therapy works. And interesting, you bring a very important point over here. And this is, again, theoretical. And please, for our colleagues, this is not based on data. Same way I mentioned about the question about keeping chemotherapy on in regard to gemcitabine durvalumab, same thing over here. When a patient progresses on chemotherapy, and let's say theoretically patients does not have a genetic alteration, in other words, no IGFR2, no IDH1, and I know you asked me in the beginning, what about other potential genetic alterations? Of course, we're always open to see, because we have a very good detailed understanding of the genetic alteration, but matter is what's targetable, what's treatable, and what are the drugs. So hopefully we'll get more. But anyway, within the context of somebody that does not have a targeted therapy, and you want to go to second-line therapy, and as you and I know, there are options in regard to second-line therapy which are chemotherapy-based, among which we can mention at least two. One of them is the liposomal irinotecan plus 5-fluorouracil, based on the NIFTY study, which again, I'm proud that to have been involved in this great effort that was led by our dear colleagues in Asan, Korea. And number two is, of course, again, from a superb team, the FOLFOX06 study that came from the ABC group in the UK as well. The question is, would you, if you declare patient progressed, just move on from just gemcitabine durvalumab to liposomal irinotecan plus 5-fluorouracil or FOLFOX and that's it? Or would you keep the checkpoint inhibitor? And interestingly, we are keeping the checkpoint inhibitor because we are really seeing it a little bit differently. And this is clinical practice. If you have to make an argument for that, insurance might say no, might not have access, and hopefully we'll have a trial one day. But this is a personal perspective. This is not based on any evidence-based data. But the argument is, biologically, the checkpoint inhibitor is like the scaffold of a building. And then the chemotherapy is like the walls of the building. So you build always a frame that has a checkpoint inhibitor, and then you slap on the wall the way you want it with the different chemotherapies. And that's why we like to keep the checkpoint inhibitor going on despite the progression per se.
So it's a matter to put back on track the immunotherapy starting from a first, maybe at a first sight, the tumor can be not amenable for immunomodulation, but if you induce more damage, you can gain some more immunotherapy targets. That's what I understand. Is it correct?
That's totally correct. You said it absolutely correct.
Thank you, Ghassan. Another defining features of this tumor is the early lymphatic dissemination. And we know that often the presence of node metastasis is detrimental for surgical interventions such as a resection or even liver transplantation. In the dawn of innovative therapies, is there any chance to target tumor-associated lymphangogenesis to reduce lymphatic spread? Because I think that the fundamental idea is to increase the localization of the primitive tumor in order to make it amenable for the curative therapy, surgery first. What is your idea on this strategy? Do you think that tumor-associated lymphangogenesis, because we know that anti-angiogenic therapies has been as a result, ended in conflicting results depending on the tumor. And in particular, cholangiocarcinoma is an hypovascularized tumor compared with hepatoma. Maybe lymphatic is a more attractive target.
Yeah.
How do you say that?
So no doubt that we're seeing more what you're asking about, which is like what I like to call it the two-way street staging of the disease, i.e., as the tumors sadly, and all tumors sadly progress from stage 1 to 2 to 3 to 4 in metastatic disease, could it be that we are seeing regression of tumors where we can go back and apply the local therapies or curative therapies, as you just mentioned, like surgery? I have to say, we are very comfortable with that argument in regard to primary liver cancer, to hepatocellular carcinoma. And we have seen that in other words, always we tell our patients, we keep everything on the table. And an example of this is, for example, what we're doing right now with the locally advanced disease with the combination of chemoembolization plus immunotherapy, which is, again, one study that we are proudly leading from Sloan Kettering all over the world. And from Memorial Sloan Kettering, we are delighted that now it's even open and accrued patients pretty much in many places. And we had the first patient in the US just last week, the Emerald-3 study, looking at durvalumab, tremelimumab, lenvatinib plus chemoembolization. Now, interestingly, though, when we go back to biliary tumors, I'm not sure we're there yet. And the reason we're not there yet, because exactly for what you mentioned, the lymphocytic spread, the microsatellite invasions per se, but nonetheless, we're thinking along that line. And if anything, here for Sloan Kettering, we already are thinking and evolving a concept of what we call peri-adjuvant therapy, where in other words, when you take tumor out, you give therapy before and after the surgery with the aim to try to enhance on those kind of, microvascular invasion, microsatellite disease. But of course, we have to wait for the study if it happens.
Oh, that's very interesting, very important. Is there any apart from pancreatic cancer, do you think because cholangiocarcinoma has very unique features in this respect. I mean, the lymphatic spread we have just talked about, but even the tumor microenvironment, the immunological coldness, and whatever you think, and even the chemo resistance. Do you think that there are some epithelial cancer that can lead the way to improve innovative therapy for cholangiocarcinoma? What is a model, a disease model suitable for this among the different, what is the most close as a biological tumor to cholangiocarcinoma?
Well, there's many models, and it depends what you're trying to ask. It's not only about the model, but we're trying to ask. But if anything, here at Memorial Sloan Kettering, we definitely build organoids. So we have also PDX models, and it depends on the purpose. For example, the PDX models mainly are done for us to really pin down the antigen potentially for a CAR T program in the future. And this is where you did not ask me yet, but if you ask me where we're going next, CAR T. Definitely this is where we're going. Cell therapy.
Okay, thank you.